The following podcast is part of a certified educational activity titled Revisiting HIV Antiretroviral Drug Resistance in the Current Landscape. Expert insights into cause, consequence, and clinical approaches to management. Access the entire activity and complete the post-test at peerview.com/XAS860. Downloadable slides and practice aids are also available.
Welcome. My name is Jürgen Rockstroh from Bonn in Germany, and I'm joined by wonderful Laura Waters from London. And we're having a program together today, which is titled Revisiting HIV Antiretroviral Drug Resistance in the Current Landscape. Expert insights into cause, consequence, and clinical approaches for management. So obviously this is a very important topic for dealing with people living with HIV and their management. Now, the goals for today are augment your knowledge of the prevalence, drivers, and implications for antiretroviral resistance. Equip you with strategies for identifying resistance and accurately interpreting the consequences of specific resistance mutations. And finally, to provide guidance on switching ART in the context of resistance mutations. So let's start with the first module, cause and consequence. And there are really three different types of HIV drug resistance we want to remind you of. The first one being transmitted HIV drug resistance. So that's something you can get when you become infected. Breakthrough infections for people on HIV pre-exposure prophylaxis, or what we call HIV PrEP. And then acquired HIV drug resistance in the context of virological failure. So let's take this step by step. Let's start with transmitted HIV drug resistance. Now, this is a recent paper from England looking at antiviral drug resistance. And I have to say, and I think Laura might agree with that, it's kind of difficult to find very up-to-date surveillance data for different countries on transmitted drug resistance. We may be different from country to country. And that's why we sort of believe that it makes sense to monitor all countries individually because different regimens are in place. There's different times how the epidemic unfolded. Now, this specific one really went through some effort to identify people with recent HIV. So to really look at the current important prevailing transmitted drug resistant mutations. And this is a cohort of 655, 95% male. Most of them were men who had sex with men, mostly white. And they received next generation sequencing. So next generation sequencing allows to find mutations at a much lower threshold. And the thresholds used in this particular study were 2% and 20%. And obviously it may matter depending on how the frequency of certain mutations may be. And you can see that if you look at the lower threshold, the rates of resistance for NRTIs was somewhat higher with 4.9%, which went down to 3.4% if you just looked at the threshold of above 20%. And that was, though, pretty much the highest resistance rate in the NRTI group. So that would be, for example, an M184V mutation. But you can see that that mutation, which we find quite commonly, was only found in above 20%, only 0.3%. So that's a pretty low figure. I have to say, though, what we should remember is that mutations which we find may not necessarily always show what has been there in the past, because over time, mutations may become lower in their frequency and may not even be detected at all. So that may be something to remember. But what you can see is that overall, the prevalence, regardless of which threshold you use, is less than 5%. So that tells you that there are not so many mutations left. So that could really pose the question, I think I'm going to ask you that, Laura, how important is genotypic resistance tests prior to starting antiviral therapy in 2025?
And it's a really good question, Jürgen. And I think plenty of people have suggested that actually in the era of modern second-generation integrase-based first-line regimens, that actually doing a baseline resistance test adds nothing. Because as you've shown here, the likelihood of detecting resistance that will impact those first-line regimens is highly unlikely. However, I think it remains important. I think, firstly, unless we're looking for it, we're not going to find it, which sounds ridiculous, but we won't know if there's an upswing in trends of transmitted resistance if we're not monitoring. And I think when we consider particularly increasing use of antiretroviral for PrEP, and particularly integrases for PrEP, long-acting cabotegravir, for example. I think it is important to monitor because it's not just the use of these drugs as prevention, but more widespread use. And we've seen in some populations, particularly those with NRTI resistance, that we are starting to see more integrase resistance emerging. People migrate, people move. And just because in the UK right now we have very, very low rates of transmitted integrase resistance, indeed with that higher threshold, as you've shown, there were no resistance mutations detected, but that could change. The other thing is that we may want to switch to lower barrier options in the future. Let's think about long-acting cabrylpivirine. We may have somebody who doesn't tolerate integrases and we want to use a non-nucleoside. And there, I think that baseline information is critical. Now, some people can store those samples and go back and look retrospectively, but not everyone can. And you may miss that golden opportunity to look for resistance at the beginning if you don't send it at the start. So I think we should still be doing resistance testing at baseline.
Yeah, so I fully agree. I mean, I remember in the old days when resistance tests became available in Germany, the mandate was that it had to be above 5% to be cost effective. And obviously what we see, it's much lower now. I would say, though, that there were periods in time, particularly when we were using mostly NNRTI-based first-line regimens, in particular efavirenz, and then considering that we had people who had, ACT or D4T therapy, even partly as a monotherapy, that the rate of NRTI resistance was higher. So people who then added efavirenz to the mix had a higher risk of virological failure. So we actually saw quite a bit of NRTI resistance. And I think one of the main messages from the more up-to-date surveillance is that actually that mutation is declining because we're not using that frequently anymore. And it's really this shift to high genetic barrier regimens has sort of brought a decline in resistance overall, which is reassuring. But again, as you alluded to, the introduction of PrEP using drugs which may not work in everyone may lead to mutations. And obviously, if we want to switch to long-acting in particular, I think this is still a very important information to have. And so we still perform it on a regular basis. And I would agree with you that this remains clinically relevant. All right. So let's come to breakthrough infections for people on HIV PrEP. Now, since England is one of the countries which has developed sort of PrEP and has been around for probably the longest time in Europe, the question would be, how often do you really see someone fail on a tenofovir plus FTC regimen? Is that a frequent occurrence? And how often do you see that M184V mutation, which would be probably the first mutation to appear under that regimen?
Yeah, so I mean, that's the thing with PrEP, isn't it? If people are able to take it, then it works. And so it's how often we're seeing breakthrough acquisitions on oral PrEP very much depends on adherence. Now, every case we've seen, and it's a handful of people, it's been in the context of interrupted adherence for whatever reason. And I think the thing is, if someone's had any recent exposure to oral PrEP, so tenofovir and emtricitabine, then the safest thing is to assume there's resistance until you know there's not. So I think, interestingly, for example, it's one of the few situations where the US guidelines recommend a protease inhibitor first line is in the context. And actually, that's around cabotegravir. If somebody's had recent exposure to cabotegravir PrEP, to start a high barrier 3-drug regimen with a PI until you know. For oral PrEP, if we don't know the resistance, then again, we should be using a 3-drug high barrier regimen, so second generation integrase, or a boosted PI. If you have the resistance test available, then the 2 study sets we have available are almost identical. 56 Dean Street, a very busy, very brilliant sexual health service in central London, but also data from New York City, both showed that in people with recent exposure to oral PrEP, it was around about 1 in 3 of people had the M184 resistance mutation. And importantly, none in London and very, very low K65R prevalence. And I think we can assume that you're not going to see K65R in this setting. Although, of course, if somebody's had very intermittent adherence and perhaps hasn't tested for HIV and could have been taking just tenofovir emtricitabine in the context of a new acquisition, then we can't assume the K65R isn't there. But it seems to be mainly 184 that emerges. And that's been our experience. I saw somebody a few weeks back with breakthrough acquisition, and they had the 184 in isolation.
Yeah. So
what about you in Germany?
Yeah. So we hardly see any mutations in failures with PrEP, but remember that is now because of the reimbursement through the health insurance. So I remember the days when people had to buy their PrEP themselves. I think they were much more likely to sort of only take it in certain situations, and that could lead to not being prepared because, sex doesn't necessarily always work with exact planning. And particularly in groups of individuals who enjoyed chemsex, where then, so time patterns shift and the regular intake was not really guaranteed. So really when there were adherence issues, particularly when you had to pay it for itself, where that was more likely to happen, I think, we did see some cases of failure. We even saw one individual with a K65R. And so obviously that would add to sort of starting antiviral therapy with some resistance on board, which is not going to be that great. So I think it's still an issue, but obviously if adherence is good and the first guaranteed for good adherence, I think is that there's reimbursement for PrEP. And that's why it's important to fight for that, because not everywhere in Europe do we have that situation. So that's important to keep in mind. So what may be a little bit different is with people who are using long-acting cabotegravir for PrEP. Now, we don't have that much experience in Europe because it's really not available in many places yet. But clearly there have been some failures, and that's of concern because it's also difficult to detect because of the low level of viremia. It's kind of not that easy to find individuals who are failing on long-acting cabotegravir, and they do end up with mutations, and that could also include an integrase mutation, and that's why we have the stronger recommendation for using then a regimen with a higher genetic barrier, in particular a boosted PI, and I think that does make sense because the likelihood of having integrase resistance is pretty high in that setting. So the last step we want to discuss here in our initial module is acquired HIV drug resistance. I think the important thing to remember is that there are regimens with very high barriers to resistance, and we already mentioned that by alluding to our second generation integrase inhibitors, which I think are sort of the cornerstone of modern antiviral treatment success, because in the randomized phase 3 trials, even after 5 years, in the very unlikely event of virological failure, there's hardly anyone, or there is no one, who developed integrase resistance. So that's reassuring. And then obviously we know from the old days and from a lot of real world data that boosted PIs also come with a very, very high, probably the highest genetic barrier altogether. Now, even though there are antivirals with less high barriers to resistance, NNRTIs in particular, and 3TC and FTC, I think we have to remember that when we give them in conjunction with a regimen with a high genetic barrier, then that may sort of change. And remember that in the old days, if you were indeed treatment naive and had no resistance, then you were very likely to respond to a combination of drugs with low genetic barrier. So it's not the only driver of antiviral treatment success, but may play a bigger role in the setting of adherence issues. Now, what we need to consider is when people are suppressed and have no history of treatment failure resistance, I think one thing we want to remember is that if we switch them to, in particular, 2 drug regimens, that we shouldn't forget to do a hepatitis B serology, because if people have chronic hepatitis B, a tenofovir element should be in that antiviral therapy to have a dual active HIV-HBV treatment in the setting of only having anti-HBC positivity. I think it's important to highlight that there have been single cases of very low level of viremia. I don't think we know what that really clinically means, because that didn't really lead to a flare and increase in transaminases or hepatic decompensation, but it's still something to remember that we might want to monitor people who switch to a not tenofovir containing regimen in the setting of having sole anti-HBC may need a little bit more monitoring. Of the recommended regimens, we have 2 drug regimens. We have dolutegravir 3TC. Remember that 3TC gives some protection against hepatitis B, but it is not sufficient. So in the Amsterdam court, we did see individuals who were seronegative and then being on just 3TC containing regimen alone still acquired a new hepatitis B infection. Dolutegravir rilpivirine, probably not that much in use anymore. And then more recently, and I think in much wider use, is long-acting cabotegravir rilpivirine. And so that's something to remember for those who are virologically suppressed, that this is a switch option. Now, in that setting, though, resistance does play a little bit of a role, because in contrast to our second generation integrase inhibitor-based regimens where we saw no resistance. There are very few cases, probably around 0.6%, but there are some cases. So Laura, in your clinical practice, are you worried about that? How do you highlight that in clinical practice, and what does that mean to you?
Yeah, I think I have been historically one of the sort of more conservative people when it comes to risk of virologic failure on injectables. And you're right, it's low. Our colleague from University of Liverpool, Sei Koo, summarised this really well in a session at the Glasgow conference at the end of 24, when he said that virologic failure on injectable cabergoline is low incidence but high consequence. And I think that's the important thing. It's a really small risk. By far, the majority of people maintain viral suppression. But the thing is, if you don't take treatments, they don't work. But the fact is, in the trials, most of the people who've experienced virologic failure has been in the context of on-time injections. So I just think it's an important part of the counselling. I think people who want injectables, but it's important they understand that there is that very small chance that despite on-time injections, viral rebound might occur. And if it occurs, they may need a different regimen. I think there's accumulating data that some people do manage to sequence to an oral integrase, but some people will need a protease. And I think it's a small but important caveat when discussing that option.
Yeah, I think what complicates the discussion is it's not really clear which factors contribute or increase the risk for virological failure. So there have been some identified factors, including high BMI, subtype A1, and the pre-existing resistance-associated mutations to lepivirine. But in the real-world data, particularly from the Netherlands, what we saw is that these factors didn't really apply. So the question is, are there just simply some individuals with low drug levels? And could that be the way it's administered, maybe not in the wrong way? And so there's still some open questions, but again, the incidence of failure is very low.
Yeah.
Well, thank you, Laura. That was a great discussion. If you're interested in more information on clinical approaches for management, just visit Module 2.
Hello, everyone, and welcome to Module 2 of our resistance journey. So we're starting with a case. So a 42-year-old woman with an undetectable viral load on tenofovir disoproxil, emtricitabine, and rilpivirine has a viral load of 2,200, and it's confirmed on repeat testing. Resistance test shows an E138K and an M184I. And there's a question about what you switch to. I'll whiz through these quickly. We have dolutegravir lamivudine. We have tenofovir disoproxil lamivudine doravirine. We have abacavir lamivudine dolutegravir. We have Maraviroc, darunavir, ritonavir, and we have tenofovir disoproxil, emtricitabine, and dolutegravir. So, Jürgen, I'd like to ask you, would you choose one of those options or would you do something different?
Yeah, I probably would do something different.
Fair enough.
I would probably give tenofovir with emtricitabine and bictegravir, just because it is co-formulated as a single tablet regimen.
Yeah, and I think that's fair enough. And I think, clearly everyone wants a single pill. The evidence in some people that a single pill makes much difference, I think, is lacking. But I think people who've struggled with adherence, and I think we can assume that she likely has. And I think if we just go through those options, why would we not recommend them? Well, there's clear evidence of lamivudine resistance with that M184I, and we wouldn't therefore recommend either dolutegravir lamivudine or tenofovir lamivudine doravirine, because again, that's a low barrier regimen and it would be contraindicated with that resistance mutation. And similarly, although dolutegravir is a high barrier drug, abacavir and lamivudine are both impacted by the 184. So currently we wouldn't recommend that. Maraviroc and darunavir ritonavir is actually a combination that doesn't seem to work, and you kind of think it should. It's a high barrier drug with a lower barrier drug, but both first line and then suppressed switch, it's been inferior to its comparators. And I think clearly answer 5 isn't wrong, but I agree with Jürgen in this situation. I think a single pill second generation integrase would be ideal, so that would have the edge, although you would expect option 5 to work as well.
Yeah,
so
well, the only thing I would say is that since the lady is 42, you also do something for preventing osteoporosis in someone who is getting older and being female.
Yeah.
So I think that would be another positive aspect here.
Yeah, although I think when your co-presenter is significantly older than 42, I'll be quite cautious about talking about age-related comorbidities in someone so young, Jürgen. But yes, I think clearly having options that reduce the risk of long-term toxicity is always a very sensible consideration. So we're going to talk a little bit about types of resistance testing. And I think the first kind of pair to compare is genotypic resistance testing, which is simply sequencing the HIV gene, and phenotypic, which is kind of what happens in vitro in the presence, like how does the virus actually replicate in the presence of a given drug. So Jürgen, when did you last request a phenotypic resistance test?
Well, you know that our virology lab was famous for doing phenotypic testing. So that's what we did in the early days because they were among the ones who developed it. But we don't use that at all anymore.
Yeah. And the thing is, I think phenotypic's important in early stages of research, isn't it? Because it tells us which genotypic mutations are important, because you might detect a change in the genetic sequence, but it might not actually confirm any loss of susceptibility to the drug. So it's that early phenotypic testing that tells us how to interpret genotypic testing. But in terms of everyday practice, which is what we're all about, then it's all about the genotype. Then the next pair to compare, and we touched on this in module 1, is population, also known as Sanger sequencing, and next generation. And as Jürgen explained in module 1, next generation gives us the ability to report mutations at much lower thresholds. And I think one of the debates is what threshold matters for different drugs. Now, the standard resistance test, that populational Sanger resistance test, typically you need 15 to 20% prevalence of resistance mutations. I think our next slide touches on that. But Jürgen, do you use next generation sequencing in your clinical practice? And what do you think is the most appropriate threshold?
Yeah, we use next generation sequencing, but I still think that the 20% cutoff is probably the relevant one. I mean, we have seen studies where you find something at a threshold of 2% or 1%, but eventually it didn't really have an impact on the clinical results. And so I think that sort of reminds us that not every detectable mutation at a very low threshold is really relevant clinically.
I think the other thing is with modern drugs, thankfully, we see so far fewer people experiencing virologic failure that you then don't generate the data that you need to tell us how important some of these resistance mutations are. Because if most regimens do pretty well regardless, it's quite hard to generate that data. Our last pair to compare, this sounds like a TV quiz show, doesn't it, is RNA versus proviral DNA. And of course, your standard resistance test on somebody with detectable viral load is an RNA sequence. But increasingly, we hear more, and certainly increasingly in our local practice, we are undertaking more proviral DNA sequencing. So that option to do a resistance sequence in somebody with an undetectable viral load by extracting latent virus from cells. So, Jürgen, there's lots of debate about proviral DNA. It might overcall, it might undercall. Is it useful? Are you doing it? And what would you say to somebody who's got a proviral resistance test and they're not sure how to interpret it?
Yeah, so we really very rarely use a proviral DNA. But I have to say, just think of a case I've seen some years ago. Was a lady who was on a T20 containing regimen and had been injecting for 3 or 4 years, couldn't find a place anymore. She had her body was covered with all these bumps from the T20 injections, which remember were twice daily. So that was a little issue. And she had no resistance tests prior to the failures. And so you wonder, whatever salvage regimen you're going to build, we knew she failed certain regimens and we could speculate that she was going to have at least a 2 or 3 drug class resistance, but we weren't absolutely sure. And then the question was, could we use Maraviroc? Could we do a tropism test? And that's all possible with the proviral DNA assessment. So it does help you, but the problem, and that was true for that lady as well, is the test didn't work. They had no sequence information. It just was not doable in that particular case. No? So the problem is that not every proviral DNA leads to test. If the test doesn't show anything, doesn't mean there isn't any resistance. Yeah. So that's a little bit the problem. But in over 40 years of HIV I think we have to appreciate that people are moving around. They can only say, I had a green tablet, I had a blue tablet, I may have failed, I can't remember. And how do we deal with, a lot of fluctuation and people moving around from treatment center A to B and then failing? So I think that's a little bit of an issue. And that's why I think there is still room for the profile DNA test, but it's clearly nothing we use on a daily basis.
Yeah. And I think that's the thing, isn't it? It's clinical history should take precedence, and we do it probably more than we should. And I think we're doing it for ourselves more than anything else. If there's any uncertainty in the history, I think where we've particularly started to do it more is where we don't know what subtype somebody is. And whilst subtype B, like many high income Western countries, subtype B has been the dominant subtype in the UK, again, because of migration and particularly we know the A6 subtype, which can impact possibly response to injectables. So as you said, the Athena cohort didn't seem to show that. But knowing someone's subtype, or we've got people who we know are subtype A, but back when it was being reported, the lab wasn't distinguishing which subtype A it was. So that's why we've been repeating ProVar DNA sometimes. Of course, if it then throws up an unexpected non-nuke resistance mutation, then you're thinking, well, what do we do with it? Because non-nuke resistance does appear to be one of the factors that's predictive. So yes, I think it can open a can of worms, and we should be careful where we're doing it until we've got more evidence.
But I think we also have to, sort of appreciate that there's so many new drug classes which people were definitely not exposed to in the past. So people have not been exposed to capsid inhibitor. Many people have never had a second generation integrase inhibitor. So we know that then you already can almost compose a salvage regimen without even worrying about prior resistance profile. So I think the question is, how's that going to play out in the future? I wonder, because we're getting, more and more drugs from new classes or new modes of action with different resistant profiles, which work in the presence of archive mutations. So that I wonder how that story is going to unfold.
Yeah, absolutely. We watch with interest. Now we touched on genotype versus phenotype. And as we said, one's the molecular sequence and one's the biologic assessment. And depending on how you get your resistance test reports, you may just get a list of the genotypic mutations, or you may get an interpretation. And that interpretation is what we tend to call a virtual phenotype. So rather than actually undertaking a biologic assessment, it's using the information that we know by entering different mutations. The Stanford resistance algorithm is probably one of the most used ones. There's the ANRS French algorithm as well. And they can then help you interpret those resistance mutations. Sometimes you can get the full nucleotide sequence. So sometimes, for example, we've been participating in an observational study and they wanted the whole sequence of each nucleotide, all the little codes. And the reason that can be helpful is there may be mutations that weren't being reported when the resistance test was done. And as we learn more and new mutations get reported, by entering an old sequence into a modern algorithm, you may find mutations that you didn't know existed. So I think that kind of summarizes it. What do you use, Jürgen? Is you using Stanford ANRS, or is there a German equivalent?
There's Genotofino is a German equivalent.
I think we should be using that as well.
Yeah.
So as we mentioned already, phenotype's absolutely not for routine practice. It's a research tool and important in early stages of clinical development. And this is just illustrating what we discussed already, that your population sequencing, some people describe it as the tip of the iceberg in terms of what it's picking up, that 15 to 20% threshold. And next generation, we've discussed already some uncertainty about thresholds. And most labs, ours also like yours, Jürgen, although we have next generation sequencing at the moment, is only reporting to that 15, 20% cutoff until we know a little more. And we've talked about ProVar DNA sequencing. This slide here summarizes that. And we talked about that you may miss resistance because you can't sequence the whole reservoir. I think really importantly, not all ProVirus is replication competent. So if you're picking up a resistance mutation that may be present in virus, it is never going to replicate. And the longer somebody's been on treatment, the less likely that virus is going to be replicable. But one thing I think is changing, and Jürgen, I'd like you to comment on this, is we've often talked about archived resistance. When I was training, I was taught that any resistance mutation that you've ever detected remains important. And that's why it's critical not to just look at a current snapshot of resistance mutations. It's important to look at the entirety of previous resistance tests as well. But that's been challenged a bit more recently, that resistance is forever. So what's your view, Jürgen? And is there a cutoff when you would say that historic resistance is no longer clinically important?
Wow, that's a really challenging question. But in the old days, the thing is that when you have someone who, for example, let's say he gets a transmitted M184V mutation, and let's say you do the resistance test 10 years later and he hasn't been on treatment over those 10 years, then that M184V is probably not even going to be found by deep sequencing, because it comes with an impairment of viral fitness, and so it's not good for the virus. So they lose the variants with the mutations disappear. But if you would give a regimen which, let's say, favors 3TC and TDF, it could well be that M184V pops up and leads to failure of that regimen. So I think it's still important, but we have seen that with the modern second-generation integration inhibitor-based regimens, for example, people who have a transmitted M184V or had a M184V through virological failure from prior regimens actually respond very well. And that has a lot to do with the fact, and I think that's what is always important to remember, that some mutations are different than others. So the M184V comes with an impairment of viral fitness. So we know from studies looking at 3TC and a boosted PI that still works better, even if 90% have an M184V versus not. And in the setting of the second generation integration inhibitors, we know that people with an M184V or even other TAM mutations still respond, because then tenofovir becomes hypersusceptible and works pretty well. So I think and that makes it so complicated, because whatever mutation that is may not be so relevant anymore in the clinical context. No? But in the old days, when we had very vulnerable regimens with low bioavailability and where the genetic barriers were all low altogether, all components, it was more of an issue. So I think we have a much more forgiving area right now.
Absolutely. And then here's just some basic principles for managing drug resistance. So the fact, and Jürgen's just explained why, because mutations with a fitness cost may disappear pretty quickly. So your most accurate time to do a resistance test is while somebody's on that failing therapy or within a few weeks afterwards. We talked about considering all historic resistance, but maybe that's being challenged. We always used to say avoid adding one drug to a failing regimen. I think the NADIA studies really challenged that, because ultimately people with virologic failure on tenofovir with lamivudine or emtricitabine and a non-nuke did better if they kept on that same backbone rather than switching to zidovudine and lamivudine. So actually, Nadia told us that changing just one drug on a failing non-nuke to a second-generation integrase or dolutegravir or darunavir actually worked just as well. But I think the key thing is that we shouldn't be using drugs that add little in the presence of resistance. So the non-nukes, perhaps less so doravirine and etravirine. Etravirine's been used in kind of salvage regimens in people with non-nuke resistance, but certainly the first generation and rilpivirine aren't going to add much. Your first generation integrases, if there's resistance, they're low barrier. And we talked about T20 earlier. Who knew we'd talk about T20 twice in a 2025 presentation? But yeah, another one that's not going to add anything in the presence of resistance. So coming back to our case, I won't go through it again. We've already talked about the pros and cons of different options. So of those 5, tenofovir disoproxil, emtricitabine and dolutegravir would be the favoured choice. But for the reasons Jürgen's outlined, perhaps a single tablet regimen based on tenofovir alafenamide, both for the convenience and for her long-term health, may be a good choice. So thank you so much for joining Jürgen and I for these 2 modules on resistance. We've certainly enjoyed delivering it. We hope that you have learned something from it, and any comments or feedback will be gratefully received. Thank you for listening.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Merck Sharp Dohme LLC, a subsidiary of Merck Co. Incorporated. To access all materials for this activity, visit peerview.com/XAS860.